Well, good morning, everyone. My name is Trevor Schell, and I'd like to welcome you all to the second of 4 webinars being held this month in observance of the 25th Annual Repetitive Strain Injury Awareness Day. Now, this week's theme is clinical lessons on key musculoskeletal disorders. We will be exploring musculoskeletal disorders such as plantar fasciitis and epicondylitis, in addition to a presentation on a new and unique way of performing a physical demands analysis. Our first session of plantar fasciitis is going to be presented jointly between myself and one of OCAL's patient health physicians, Dr. Pravesh Jugnundan.
Good morning and good evening, depending on which part of the world you are at. First of all, I want to thank Trevor for inviting me to do this presentation. I have to say most of it has been his work with some of my input. For those that don't know Trevor, I've worked with him at the occupational health clinics. My tenure there is at least 15 years. Trevor is one of my go-to ergonomists for anything ergonomic. He's very detail-orientated, thorough, and if you get to read some of his reports and research that he produces, I think it's excellent. And, at the end of the day, it makes my work so much easier. Thank you, Trevor. So what is this? This is an inflammation of the plantar fascia of the foot. And over the years, it's been known as various different names: painful heel syndrome, police heel pain syndrome, subcat pain, runner's heel, and a whole lot of other things. This is one of the most commonest cause of heel pain, approximately 15%. We know that a significant amount of these patients are overweight, up to about 65%. The peak age group is between the ages of 40 to 60, and it tends to occur more in females than men, depending on the literature, 2 to 1 or 3 to 1. The foot is a very, very complex structure, and the plantar fascia runs from the heel bone to the ball of the foot. And on your view, you see the dense fibrous tissue on the right side. That's literally how the plantar fascia looks, but obviously more brown in the real person. But it's a thick, very thick, fibrous, dense tissue. The central part is the main component of the plantar fascia, and to the inner and outer aspect, you have the medial and lateral components of the plantar fascia. The main purpose is to support the longitudinal arch of the foot. Like if you think about a bow and the string, the plantar fascia is a string that supports the arc of the foot. That's a bow.
Now, to truly understand the plantar fascia, we need to understand its role and function. Now, when is the foot the most active? During the walking or gait cycle. So gait is the manner or style of walking. The gait cycle is a consistent repetitive pattern involving different steps and different strides. A single step consists of 2 parts. The stance phase, which occupies about 60% of the gait cycle, during which one leg and foot are bearing most of or all of the body weight, and then the swing phase, which occupies 40% of the cycle, during which the foot is not touching the surface and the body weight is borne by the other leg and foot. In a 2-step cycle, both feet are in contact with the floor at the same time for about 25% of the time, which is called double support. So in this example, this person's leading with the right leg. So we start the stance phase from 0% to about 60%, and then the swing phase from 60 to 100. Conversely, the left leg is alternating. And then we've got that double support phase, which occurs between 0 and 10% and 50 and 60% when both feet are actually in contact with the ground. Now, the gait cycle also has a number of phases. Heel strike, which is initial contact, which begins the movement of the foot when it touches the ground, and it's the first phase of double support, and that starts that gait cycle at 0%. The next phase is the loading response phase. This is when the body absorbs the impact of the foot. The mid-stance, when the body is supported by one single leg and begins to move from force absorption at impact to force propulsion to move the body forward. The next phase is heel off, which begins when the heel leaves the floor, and then finally toe off, or pre-swing, when the toe leaves the ground. So again, in the example, looking at the right leg, at 0%, the heel strikes the ground or has the initial contact phase. At 30%, the right leg is at mid-stance, and at 60%, right toe off. So that ends that single support phase. And then, I said, the left leg works alternately. Once you hit right heel strike again at 100%, the cycle begins once again. Now, during the gait walking cycle, the plantar fascia functions during the single support phase, when just one foot's in contact with the ground. During this time, the foot structures experience a higher vertical ground reaction force and larger acceleration than any other time in the gait cycle. As the heel lifts, the plantar fascia begins to stretch and tense. The higher that the heel lifts, the tighter the plantar fascia gets. The fascia itself acts to elevate the foot's medial longitudinal arch and regulates movement about the ankle and distributes force evenly across the foot during loading. Now, this is known as the windlass mechanism or the windlass effect. So the windlass effect is a mechanical action that enables the foot to support the body weight and also to move. Now, as the heel lifts, it uses the ball of the foot as a fulcrum, and the plantar fascia tightens and actually pulls the heel towards the forefoot. This effect will heighten the arch and resist the increasing body weight from having the foot flat. This action, along with external rotation of the leg and contraction of the gastroc and soleus muscles, contribute to stabilize the foot and the subtalar joint. So again, as we walk, the plantar fascia wraps around the metatarsal head and pulls the calcaneus towards the toes. I have a short video demonstrating this.
Also look at that in weight bearing. So again, as I bring my foot on the floor, as I pull up on that big toe, we can see that again that medial arch becomes that little bit more prominent. Now, the important point is that as we want to walk, as we want to run, we need available first metatarsal, first MTP.
So what was showing in that video, when that foot was being brought upwards, that is when we're at peak strain on the plantar fascia, because it's now been stretched completely as this next stride begins.
So symptoms of plantar fasciitis, the primary symptom is pain, and that is generally how the patient will present. They complain of gradual onset pain, usually starts when they initiate walking, and as they continue to walk, the pain will resolve. Usually the history will tell you that, it's of gradual onset. I had it a few days, slowly it's been going worse, and over the last month it's kind of worsened. The pain is usually localized to in and around the heel area. Like I said, the pain is there for the first few steps. There may be pain when using the stairs. Generally, during exercise, the patient will tell you they're okay, they don't have pain at all, or they have barely minimal pain. And generally 1 foot at a time. It's relatively uncommon to have both feet involved. Usually with both feet, it's some traumatic event or some systemic event that's happening. Other associated symptoms may be stiffness and swelling of the Achilles tendon or around the ankle joint. The next slide will relate to the diagnosis of plantar fasciitis. This is usually a clinical diagnosis based on history and clinical examination. And the clinical examination, if we talk about a focused clinical examination related to the foot, there's usually localized tenderness just to the anterior part of the heel. And this can be elicited by dorsiflexing the toes, as shown in the diagram, and applying pressure in just the front of the heel region. Associated with this, you may have decreased flexion and tightness of the ankle joint. And you will also want to examine the Achilles tendon to look for tightness there. So usually clinical diagnosis, plain and simple, stretch out the toes, apply pressure to the heel, in and around the heel area, and the patient will complain of pain. The history, I discussed some of it previously, but basically your history, you want to exclude secondary causes of this, and you want to make sure there's no other symptoms to point you in a different direction. You know, the high arch or the flat foot is usually not on history. Usually that's part of the clinical examination. Your history, you want to cover things like, you know, is there traumatic history? Is there systemic issues like fever, or your patient's diabetic? That will possibly take you down a different road. The next slide will relate to the differential diagnosis. Like I said earlier on, foot is very, very complex. It's made up of the bones, the muscles, the tendons, nerves that run there, and soft tissue. So we look at the neurological system. You can get nerve entrapment, similar like you get at the wrist, carpal tunnel syndrome. On the foot, it's a tarsal tunnel syndrome. You can have neuropathic pain, especially a S1 radiculopathy starting at the back. You may or may not have your patient complaining of low back pain. They can present with just foot pain. So typically your nerve-related pain is, in character, it's a little bit different. They'll complain of pain. They may have numbness, tingling, burning, altered sensation, weakness of the ankle, absent ankle reflex. So history-wise, just the character of the pain is different. Differential related to the skeletal system, you may have a stress fracture or a bone contusion, usually some traumatic event. Osteomyelitis, you're going to worry about this. This is a bone infection, especially, you know, if your patient is presenting with foot pain and fever, if there's a history of, you know, a distant trauma, like, you know, I stepped on a nail a month ago, now my heel is paining. You're going to worry about osteomyelitis, which is a serious issue, infection in the bone. Neoplasms, a possibility, rare. Paget's disease and a Haenlen's deformity is at the back of the heel. Soft tissue differential diagnosis, Achilles tendinopathy. There's multiple tendons that run in around the ankle joint and under the foot itself. So any of these tendons can become inflamed and give you pain in the foot itself. Usually this type of pain will be continuous and increase with activity. You can get atrophy of the fat pad. The heel pad itself can atrophy. You can get bursitis around the multiple tendons. Common bursitis is around the Achilles tendon. You can have a painful heel pad syndrome, usually common in runners. You can have rupture of the plantar fascia with this total rupture. This is usually quite traumatic. And commonly, not commonly, I should say, other systemic issues are your inflammatory disorders, rheumatoid arthritis, other autoimmune conditions, sarcoidosis. The next slide will demonstrate the various structures of the foot. I spoke about the bones and the complications from the bones, and on the medial side, you can see the flexor hallucis longus tendon that curls the toes inwards towards the floor. Flexor digitorum longus, these tendons can be inflamed, and associated with these are your nerve structures that also run in the same region. The diagnosis of plantar fasciitis, that will be on the next slide. This is you. And if we talk about testing, usually testing is not a requirement because it's a clinical diagnosis. You generally don't need any investigations. You don't need any lab test. If your patient is not responding to conservative treatment, or if off the bat you're worried about some secondary cause, that's when you're going to do investigations. So if your patient's not worried and you're still thinking it's plantar fasciitis or some musculoskeletal tendon issue, and there's nothing urgent that's happening, you can do an X-ray to rule out other conditions. You can do an ultrasound. Usually the test of choice is an ultrasound because it measures the thickness of the plantar fascia. And if you see the image on the right foot, the thickness is demonstrated as being significantly smaller than the left foot, where the plantar fascia is much thicker, demonstrating that this patient has plantar fasciitis. MRI or CT scan if you're worried about a bone fracture or infection. The diagram at the top shows evidence of a heel spur. Heel spurs are generally common, and in and all by itself, it doesn't usually cause any major issues.
So now we're going to examine some different causes or aggravators of plantar fasciitis. So one of the many factors that can affect the plantar fascia is related to Newton's third law of motion, which is for every action is an equal and opposite reaction. This pertains specifically to what's called ground reaction force. So in this example, when we walk during the single support phase, our foot on heel strike impacts the ground and exerts force. At the same time, the ground exerts that same equal force back onto the foot itself. So if you look at the upper right corner, we have the heel strike and then the foot moving through that single support phase. And you'll see that there's two peaks when the heel's actually striking the ground and when we're pushing off to actually start the next start of the gait cycle. Now, ground reaction force can also be affected by factors such as hard floors, footwear such as a hard sole or a heavy weight, and also the speed at which we're coming in contact. Because again, if we're running, we're going to actually have a higher impact force, which is then going to have a higher ground reaction force acting back upon the body. The other examples in the images here do show that padded heels, if I have to padded heels and a thick sole, you'll notice that it actually prevents the foot from bending. So again, in that upper picture, you can actually see that movement of the arch. So a hard, rigid sole shoe actually prevents the plantar fascia from actually using the ball of the toes as a fulcrum and actually allow that full propulsion. Now, another factor is footwear. Shoes with inadequate cushioning, such as the hard sole or poor design, may lead to additional micro tears with repetitive traction, resulting in an inflammatory response of the plantar fascia. A sufficient work boot, for example, must provide both heel and arch support in order to reduce the strain placed upon the plantar fascia. They should also be relatively flexible to allow for a proper toe off, and the feet need to make a rolling motion with every step taken. As a result, the boot needs to bend along with the foot. If it remains stiff, unnecessary pressure is applied to the sole of the foot, which can also irritate the plantar fascia. So in the graph below, it's a comparison of the ground reaction force of a soft padded shoe, which is the solid line, compared to a hard sole shoe, which is the dashed line. So again, the ground reaction force is actually much higher with that rigid sole that's not allowing the plantar fascia to actually function as it needs to do properly. Now, this one's actually quite interesting with respect to stair climbing. I never really noticed this until I was working on a compensation claim once for a worker who actually had plantar fasciitis. She was claiming that she had to climb 10 stories of stairs once an hour to check on something and then descend again. And so I actually went out to our back fire escape and started walking up and down the stairs. And I actually realized that when we actually walk up and down stairs, we're using our toes. Our heels very seldom ever come in contact with the stair surface when we're walking. So this places the metatarsal joint in a state of dorsiflexion until the next foot takes over support. It's the same mechanism that occurs during the normal gait cycle with toe off. except the position is held for a longer period of time, depending on the number of stairs we climbed. So in the case of this worker, she had to climb up 10 stories of stairs, which is a lot of time to be spending on your toes. This results in increased stress being placed upon the plantar fascia. In simple terms, the plantar fascia is stretched and subjected to micro tears during stair climbing and descent. This greatly increases, again, with the use of rigid sole footwear, such as steel-toe boots, which requires additional effort to push off with the toes. Now, also, when I say rigid sole footwear, I'm not just referring to work boots. I am referring to high heel shoes, for example. They're all very rigid. You don't see nice padded high heel shoes. Another risk factor, of course, is increased body weight. This has two effects. One, as we gain weight, our center of gravity is altered. And as a result, the body must adapt to this change. And of course, it's the feet's responsibility to adapt to that weight bearing to support the body during the gait cycle. The increase in body weight also has a large impact on the ground reaction force, because the more weight we are, the harder we are actually going to hit the ground with every heel strike. Riddle in 2003 stated that people who spend the majority of their workday on their feet and whose body mass index is greater than 30 are at an increased risk of the development of plantar fasciitis. In the graph in the lower left, you can see a comparison of someone with a higher BMI compared to a lower BMI. So, that does have a huge effect with how much weight we're actually hitting the ground with. Conditions like genetic foot conditions such as flat feet or pens planus. This causes overpronation, which occurs in the walking process when the arch collapses upon weight bearing. This causes the plantar fascia to become stretched away from the heel bone, whereas a high arch or pes cavus causes excessive strain on the heel because the foot does not effectively avert and absorb shock during the walking. Another one is leg-like discrepancies. So we have one leg that's longer than the other. And surprisingly, most of us do have one leg that's slightly, like a couple millimeters longer. But for some people, they actually have a very pronounced difference in their leg lengths. This causes an uneven distribution and transmission of the ground reaction forces to the feet. There's a compensatory mechanism such as excessive hip and knee flexion or excessive hip circumduction, which all increases stress and tensile forces on the plantar fascia. It commonly affects the longer limb because the greater forces are transmitted to that foot on the longer side, because that's when it's going to be in contact with the ground more during the gait cycle. So in the image on the right, the leg that's red is actually longer. So what happens? It changes the orientation of the shoulder. It changes the tilt of the pelvis, causes rotation about the knees, and causes that drop in the arch of the foot.
Tight Achilles tendon, if you think of yourself standing on the ground and lifting just your foot off the ground, that will be your dorsiflexion action. So if your Achilles tendon and your calf muscle is tight, it will be pulling in one direction, and your heel is being basically pulled in two directions. Because of the tight Achilles tendon, the plantar fasciitis is being stretched, and that produces extra tension in the plantar fascia, causing the problem. The next one will be what we call genu valgum. Those are knock knees. So if you are standing straight and you watch yourself in a mirror or someone's looking at you, you'll find that both your knees start to touch. They come inside and they touch. And what this does is that the inside of your foot rotates, and there's more pressure on the inside of your foot, and this causes a strain on the plantar fascia. So if you are sitting down with your feet apart at this moment, you can just get both your knees to touch, and you'll see your foot turns inwards. So that's where the extra pressure is, and that's why you end up with plantar fasciitis. The next one is overpronation, and Trevor did discuss some of this. is usually related to a poor arch and flat foot. So overpronation, there's excess foot mobility, which increases the stress applied to the plantar fascia, and this causes an elongation. It alters, from this diagram you can see the pronated foot, the center of pressure and application of the ground reaction force. On the diagrams on the right, you can see that the ground reaction force from the second toe, that's the one next to the big toe, is shifted to the fourth toe. So this change in force and distribution is what affects the plantar fascia and causes the problem. Age, as we know, as we get older, the fat pad that protects the heel becomes thinner and it starts to degenerate. This is just a physical thing that leads to inadequate padding in the heel region, and it can cause either a problem with the plantar fascia itself or just plain heel pain. Gait analysis. Trevor spoke about the leg length discrepancy, and he had that diagram up, and that's why from a physical perspective it's very important to look for any correctable biomechanical factors. And the reason why it's so important is that you can personalize the treatment plan, looking at what's wrong. You can prevent a recurrence if you correct anything that's abnormal in the gait, and if the patient is in rehabilitation, you would want to monitor it. The other point of importance in a gait analysis is that from the diagram that Trevor showed, you can see that the mechanism is all from the low back, the pelvis, the hip, the knees, the ankle, and the foot. So if you imagine your patient with an abnormal gait, I mean, the plantar fascia or the plantar fasciitis may be the first presenting symptom. So if you leave that untreated, you can be sure that your patient is going to come back with some other joint complaint, whether it's a knee or whether it's a hip or whether it's a low back. So it's always important to look at the gait. And usually, you know, someone needs to understand gait and the mechanism of it. A physician that has some experience in this. The physical therapists definitely have, you know, a good understanding of gait and gait analysis. That's a physio and the chiro. Chiropodist and podiatrist, definitely, you know, they focused on the foot, but they have a role to play too. In terms of treatment, the number one most important thing is activity modification. If your patient is involved in some activity that's either causing or aggravating the condition, you know, doing long distance running or skipping all the time or jumping up and down, those are obvious aggravating factors. So you want to modify that. In terms of medication, anti-inflammatories are the first line. Any over-the-counter anti-inflammatory should do. Ibuprofen, naproxen, Aleve. Ice works well. Just a cold water bottle, rolling it under your foot 15 to 20 minutes, 3 to 4 times a day, that works. Following your gait analysis, you can recommend supportive shoes, inserts, or orthotics. Usually I just look at the shoes and look at what they're wearing. You know, are they using dress shoes all the time that literally lacks all supports, or are they using running shoes that have totally worn out? So it's always good to look at the inside of the shoes and the outside of the shoes. And looking at the outside of the shoes, you can look at the wear and tear, and that tells you what's happening, especially if one is more worn out than the other. Stretching, and I spoke about the tight Achilles tendon, so the stretches you can do. These are readily available on the internet, and you want to stretch both, right, starting from the front, the toes to the ankle. Taping helps. Again, this is usually done by the physical therapist. Shockwave therapy, this sends out pressure waves, sound through the skin, and it basically initiates the healing process. Cortisone injections usually works quite well. This is usually if conservative treatment has failed and your patient's battling, you want to consider cortisone injections. The only downside of a cortisone injection is that it's generally painful, because that site of injection is quite dense. So you're injecting fluid into a dense area, so it does cause pain, but it's very short-lived, and the benefits are great. Plasma, platelet-rich plasma, where they take out your own blood, spin it down, take your plasma, and re-inject it into this area. It's all to stimulate healing. Dry needling is also done in certain clinics, and again to stimulate blood flow to the area and help healing. Casting is probably a last resort if you just need the leg to kind of rest and take it easy. The next one is surgical treatment. Usually after 12 months, you're stuck with the patient, you've tried the conservative management, you corrected the gait, you've done the footwear, you've tried cortisone, you've tried other injections, you've tried various anti-inflammatories, you have modified the activities, and you're stuck. You may want to refer them to a surgeon. From my many years of experience, even the surgeons are very, very reluctant to do these operations. I'm not sure of the exact statistics, but I don't think the outcomes are, even greater, unless there's some nerve entrapment, tendon entrapment, chronic bursitis, something obviously identified more than the plantar fascia itself. They may go in, but otherwise it's rarely done for pure plantar fasciitis. Probably more expert centers.
So now that we've learned about the condition, what can we actually do to try and minimize it? Well, the first one would be proper footwear, such as the weight and also the type of sole. I just did happen to do a comparison of a steel toe boot versus a composite toe boot. Note the difference in material, once again, a steel toe cap, whereas the composite is either a carbon fiber, Kevlar, or fiberglass. Price, the steel toe is cheaper, whereas the composite is more expensive. Benefits for the winter, steel toe is colder in the winter, composite has more thermal insulation. But the key factor here for plantar fasciitis is the composite toe boots weigh about half the weight of the steel toe. So again, that's going to act to actually decrease that ground reaction force, and also tends to reduce overall whole body fatigue and tiredness with having less weight on the feet. Pravesh mentioned orthotics. Now, these are designed to help maintain the arch of the foot. At the same time, also try and correct any abnormality. So in the example on the right, or on the left, sorry, it's that red blob is actually the orthotic to try and reduce that overpronation and turn the leg back into having that sort of straight ground reaction force going right up and down, as opposed to acting on an angle, which is going to put strain. Of course, orthotics as well can also be used in work boots, running shoes, dress shoes. They're meant to be taken out and moved to your different footwear that you're actually going to be using. Work surface is another factor. I mean, the harder the surface we're working on, the harder the ground reaction force is going to be acting back upon the body. So, if you're standing for prolonged periods of time, things like an anti-fatigue mat to give you some cushioning. Some work boots actually have an anti-fatigue insole built right into the boot to reduce impact. And there's also anti-fatigue overshoes that can be strapped over top of work boots to help absorb and reduce that ground reaction force on impact. Basically, they're like an anti-fatigue mat that's mobile. You want to avoid things like flip-flops. Now, I'm not talking about Crocs. I'm talking about those cheap little flip-flops that you see in the right corner with a very thin sole, because there's no absorption of that ground reaction force. We need that cushioning and padding. You want to avoid high impact activities such as running when you actually have plantar fasciitis. You want to give your tissues a chance to recover. And of course, diet weight loss will also help to reduce any ground reaction forces.
I just want to mention something on foot orthotics. Besides the plantar fascia that maintains the arch, the foot itself has multiple other structures, and one of them are the muscles of the foot. So one of the things is that you need to strengthen those foot muscles. So when you are not using those orthotics, you need to do specific foot exercises to make sure you keep those muscles strong, or you regain the strength of those muscles. Because if you kind of every single time you get sort of addicted in inverted commas to foot orthotics, you're not using those muscles as much. So foot exercises to strengthen those muscles as part of the rehab is also important. I thought I'll just mention that. So in terms of workers' compensation, and this first slide should have said accepted. So what I did in Ontario, I looked at the Workers' Appeal Tribunal. So it means the case has been rejected at the level of the Workers' Compensation Board, and it's been appealed to the Appeal Tribunal. And the Appeal Tribunal has made a decision. So we spoke about how the causes are not directly related to work. And then I pulled out 4 cases, 2 that were accepted, 2 that were denied. The first one was accepted that we have up here. But I thought the discussion was great, and it kind of says what I want to talk about today. So the panel, and this is a 3-person panel, you have the chair and two accompanying members, one from the workers' side and one from the employer's side. And they agreed that the mainstream view that plantar fasciitis is usually not considered to be related to occupational factors. So they accepted that. Then they went on to say, however, the characteristics of each individual worker are an important factor in the likelihood of developing plantar fasciitis. So they said, we have to figure out what's unique with the worker. And then they said the activities that the individual is engaged in serve as possible causative factors as well. So they said, look at the worker and look at the activities. And this panel was satisfied that this worker's prolonged walking and standing at work, coupled with the use of inappropriate footwear, significantly contributed to the onset of plantar fasciitis. So in this case, the requirement for the footwear was part of the job, and the footwear was provided by the workplace. So the fact that they could demonstrate that the footwear was inappropriate and the worker kept requesting proper footwear, these factors were enough to satisfy the panel that there was some work-relatedness. So they basically said, while work-related factors may not have been the sole cause of a plantar fasciitis, the factors combined to play more than a de minimis role, so more than a minimal role in developing plantar fasciitis. The next one was basically the panel ruled that the condition was not a disablement from the nature of the worker's work. So basically saying because you did this type of work, it did not naturally lead to plantar fasciitis. The evidence provided did not support the claim of prolonged standing and walking while wearing safety boots. And once again, they said there was no consensus in the medical community concerning the causes of plantar fasciitis. This is a case of a letter carrier where the panel said, you know what, we accept the fact that just the nature of your work contributed to the plantar fasciitis, because there were supporting medical opinions from the workers treating family doctor and physiotherapist that showed that the workplace duties, including a lengthy mail route. So they were able to describe that this mail route was different from the routine, and it also involved a significant amount of uneven surfaces which the worker had to walk in. So, whether it's snow or slush or uneven terrain or delivery in rural areas. So they were able to accept that. And the last case, also a letter carrier, and the panel basically said it's not a disablement, so it's not just due to the nature of the work. And the tribunal also had their own medical discussion papers, and obviously the discussion paper, as we alluded to previously, said that plantar fasciitis causes are uncertain, but not obviously work related. I think that's my last one. Thank you, Trevor.
Thank you, Pravesh. Okay, so we're just going to open the floor to any questions that may be out there, Dwayne.
I think we have to unmute Dwayne because I was having the same problem.
Yeah, I'm That's what I was saying. Okay, yeah, there's a fair number of questions here, but just so that the people in the chat that asked the questions, I'm going to try to skip the ones that both Pravesh and Trevor did answer as they did the presentation. So I guess first one is a question. The person said they're puzzled why pain occurs after getting out of bed. So I guess the question is, why is there pain from rising and getting out of bed? I guess that would be a question for Pravesh.
Yeah, I think it's related to the initial stretching mechanism of the plantar fascia, that when you're sleeping, there's no forces there and it kind of shrinks down. And when you start to ambulate, the stretching is what causes the pain.
Okay.
So therefore, once you have stretched it out, it just stops paining.
Okay. Can you talk more about how padded heels increase force? This one came up when Trevor was speaking, I believe.
Okay. Sorry, what was the question again, Dwayne?
Can you speak more about how padded heels increase force?
They don't increase force. They actually reduce the ground reaction force. So the more cushioning you have in the heel of your shoe or on the sole of the shoe, it's actually going to cause more absorption and reduce that impact of ground reaction force when you strike the ground.
Okay. Thank you. I guess I didn't catch what you were talking about then. Okay. Can you talk about the impact of rocker bottom shoes? I'm guessing they're asking if they're good or bad for plantar fasciitis. I guess if they're talking about those round ones.
I'm not sure what a rock bottom shoe is.
Okay, then let's move on.
I see them advertised to lose weight or strengthen your feet, but I have no comment on
Is that like the barefoot shoes, or is that different?
I think it's different. It's meant. I think you use more forces in terms of when you use those shoes. And
oh my, yeah, I just googled it to look at a picture of it, and it's almost like a rocking chair. Like your feet aren't even flat in contact with the ground at all. They're actually, most of the pressure's directly on the arch of the foot.
Yeah.
I really don't know anything about them to comment.
Okay. So I think someone just wants some clarification here. Do you want to do stretches, exercises to actually physically stretch the plantar fascia in order to potentially avoid this and or treat for it? I know one of you spoke about stretching at some point, but I think they're asking.
Pravesh.
Yeah, you definitely want to do stretches, not only the plantar fascia, but everything in around the foot, right from your ankle to your Achilles tendon and your plantar fascia. So you want to keep that all flexible and mobile. Just like you want to stretch any other part of your body, whether it's your low back, your shoulders, your neck. So it's the same sort of theory, stretching and warm up.
Okay, question about the orthotics, I guess. Would you recommend, or is it just as beneficial to purchase, over-the-counter insoles?
Yeah, I think unless there's something very obvious and obviously wrong with your foot, but most people can get away with over-the-counter orthotics from my experience. Some stores have a sort of impression thing you can stand on, and it gives you a printout of the different pressure points and makes recommendations for various orthotics that you can buy over the counter. I haven't, unless there's something definitely wrong with your foot. Most of the time over the counter ones will work. If you're overpronating, it'll be probably better to go to a professional to get that fitted properly. There's also harms from using incorrect orthotics, so be careful to where you go for the orthotics. I always tell patients to go to a place where they do it in a house. That's my preference, because then they can mold and cut and reshape and do everything until it's comfortable. They can observe you walking and they can make the changes there and then. I find that places that kind of take an imprint, mail it out, come back, not fitting, try to adjust it, mail it out, come back, you're probably not getting the best service. So those are my recommendations.
Yeah, I mean, the other thing too is that there's a difference depending on where you're buying them from and everything. There's a difference between an insole and an orthotic, in that for some companies, an insole is literally just cushioning, whereas the orthotic is the custom mold to maintain the arch and the support of your foot.
Excellent
Okay.
point, Trevor.
Did you have something else to add there, Pravesh?
No, I said that was a good point Trevor made.
Okay. One other one we have here, as an employer, what education should we be providing to our employees who are on their feet all day for selection of footwear and preventative measures?
Well, again, I think the one thing is depending on the nature of the industry. So if it's something like a healthcare setting, like a hospital, proper, good quality cushions of footwear. Um, if it's something more industrial where there is safety boots are needed, um, I know, like, if depending on the nature of the work and the stuff required, the composite boot would actually be preferable, just because it is half the weight, um, that reduces the amount of impact with foot strike.
Okay, couple of questions here, I think, pertaining.
Just a comment on that. I often, I mean, if you follow Trevor's advice, I think that's good. But what I see more often than not, people have the correct footwear. They just fail to replace it at the right time. It does not last forever. So
No, exactly.
depend how long you're on your feet and how much activity you're doing. It may look out good on the outside, but the inside and the soles are all worn out. So try to figure out your lifespan of your shoes, and averaging, I don't know, 6 months of you on your feet all day, you should seriously think about replacing them.
Okay, this is another one regarding the shoes there, and I guess entitlement. Is the requirement of safety boots / shoes sufficient to support entitlement? For the first example, I guess this was referring to a couple of the cases you spoke about there, Pravesh.
No, you have to show that there was some problem with the footwear. In that specific case, I think the company was providing the footwear, and there were various complaints from the worker that the footwear was not the correct one. It was, ill-fitting footwear. So the ill-fitting footwear, you're not going to get proper protection.
And another point too with that as well is the vast majority, and Preventative and I have talked about this, the vast majority of claims for plantar fasciitis, it's not caused by work boots. It's you have an underlying condition that's being aggravated by the rigid sole. That's the one key thing to remember, is there's vast majority of the time there's an underlying condition that's being aggravated by the workplace factors.
Okay, so I'm assuming that you guys have answered this next question by what the two of you just stated there. The question was, if a teacher or cashier is on their feet all day and is diagnosed with plantar fasciitis, would this not warrant entitlement?
I think from the cases we looked at, you have to show something more than just being on the feet, on your feet all day. So you have to combine that with something that that's unique to the worker itself or the job itself, that's different from the regular. So it's like the thin skull effect. Because this worker has knocked knees or a hip problem or an ankle problem and was needed to stand for so long, and therefore there was an individual contribution to that, or the worker was required to go out on a field trip that required the teacher to be on her feet whole day and walk across gravel and up the hill and down the hill or whatever. That was more than just standing in front of the classroom. So I think from what I've seen, if you can combine the workplace with some individual factor and some different thing that occurred in the workplace, you're more likely to be successful.
Okay, one last one here pertaining to the cases that you spoke about there, Pravesh, as well. When was the decision for the letter carrier made?
That is a good question, and I saw that flash across the screen. It could have been a while ago, and I got the references somewhere, but I didn't put it here. So no, there were some old decisions, and things have changed with time. So I don't have the answer.